Thank you. First of all, I must say thanks to Pailajani sir, Satyavan Sharma sir, Dr. Shiva, Dr. Nivas sir, for and Intas for be persistence for such kind of academic activity. And after listening to the AI talk, now I'm again going back to our traditional method. And I would like to add one point. Today's era, the most successful person will be who is ready to adopt the new environment rather than fix to his own criteria. And the second important message is there should be a concept of integrated internal medicine. You know that cerebral malaria, previously the drug was only the quinine, but it has a lot of toxicity. We had lost many life because of the cardiac toxicity. But the Chinese, their herbal medicine is artisanate, and they come up and now we can treat cerebral malaria at home also. The same thing is our Charak, Susruta, Komarya Vignam. They are having their own values. Each leaf has its medicinal value. So same thing, if you want to grow, obviously science and technology is like a work in progress, but we should not forget our roots because there should be, and now in the being in a university hospital, we are seeing a lot of the today's era, the implants and devices are playing the role in the playing the major game in health industry. I, being an examiner, my criteria of passing the candidate is not to see the theory, because everybody is well versed with on the fingertips. If person is conscious about not to harm life by doing unindicated thing, then I will clear that person. Because of all this technology and all, obviously you have to take what is relevant for your practice, but you are ready to adapt the new things. The same time, you should not forget your roots, because clinical examination, history, you will drive the persons in a specific path rather than bombarding everything on the same platform. Thank you. So the question, my topic is very important, the jugular venous pulsations. It is also, I think all of the candidates, they want, whenever they try to tell the history, they try to avoid JVP, or they try to misuse that word. And it is not being, they are getting scared कि अगर JVP बोला और कुछ फंसे तो गए. Yeah, they try to correlate and try to pass it off. So let's make it simpler. I will try to make it simpler. What is JVP? There are two forms, the jugular venous pulse and the pressure. The pulse is, it is a, defined as a oscillating top of the vertical column, and it reflects the right atrial pressure. So what is the JVP means? It is a windows for the right heart. It indicates the hemodynamics of the right heart circulations, and the pressure is the top of the height of the oscillating column. So see, this is the height of the oscillating column, which is a direct communications with the right atrium, and the different oscillating waves, the right atrial contractions, filling, emptying, that creates a waveform, and that we are counting as a JVP pulse. Now, before we start the journey, we should not forget our legends who had identified those pulse and the pressure wave. One is Sir Mackenzie. He developed the monogram, and that he record the arterial and the venous pulse. And obviously Paul Wood, all of you, you are not reading the Paul Wood article, then you are not fit for any of your exams, because he is like a, I can say his books I consider as a Bible of cardiology. And he described the book Disease of Heart and the Circulation. Eisenmenger articles, you are not going to clear the exams if you had not read the article, each line of it. And you can see the person with the mustache and the wine in his hand, the Sir Lewis. He had developed the technique of how to measure the JVP, the bedside assessment of the JVP. So we should salute those who had given us the clinical informations about the JVP. Now what is JVP? Usually it carries around 70 to 80% of the circulating blood. Most of us should know first once your mind knows, then only your eyes will see. So this is how the JVP course is. It runs between the two heads of the sternocleidomastoid and from earlobe to the middle end of the clavicle, and it is into the lateral to the carotid. And usually it lies deep to the sternocleidomastoid junctions. Okay, external jugular is usually superficial. Can you make out all this landmark? So you should correlate with the human body. Okay. Now why the internal jugular is preferred than the external? Because internal jugular has a direct connections with the right atrium, and it correlates with its hemodynamics better, whereas external jugular can be easily compressible. It has indirect connections, and when patients with heart failure and all, it can be easily compressible or disappear. Now, why right over the left internal jugular we should consider preferred? Because right is in the straight line with the right atrium. Okay, it connects directly SVC to the RA, and it less likely to be compressed by any of the three. Whereas the left has a large innominate vein, so any intracardiac mass or structure may give like a false impression of that. And this is how the venous course, you don't have to remember, but only remember that internal jugular runs from the earlobe to the middle end of the clavicle. Now, you must have seen that first of all we don't make an attempt to see the neck. Today's we just directly put the echo probe. So neck is again very important to know the vascular volume of the patient. And certain patients, I do admit, it has a low sensitivity and specificity. Even the experienced cardiologist has a 65% sensitivity and 85% specificity. But it does plays a very important role. So in a child less than 12 years, you should not make an attempt, because sometimes it is difficult to obtain. But in adult patients, if you have to see the volume, if hypovolemic, make it lie down flat. If it is very much dyspneic and the veins are anchored, you can make it angle more vertical. Okay. And how to examine? Always make a patient in a relaxed positions with the reclined positions of 45 degree, slightly head tilted and towards the left. But don't make the patient stress. Patient should be avoid of doing any Valsalva maneuver, exaggerated breathing, or any kind of a breath holding activity. The light should be come from the back and at the triangle of your sternocleidomastoid. So you can see the wave and observe the oscillating movement. And then you have to measure by putting a two horizontal scale. One is at the top of your venous column and another is at the angle of sternal angle. And you have to measure the vertical height. So this is how, and most of them they said okay, we auscultate the heart sound and we say which one is precede, and it is very difficult. So better to palpate the carotid and see outward movement or inward movement, and that makes life very easy. Which are the waves who is moving outward and which are having a collapsible waves, and then and with carotid or without carotid. So you are making the slightly tinted positions, palpate the carotid, focus the light, and you can diagnose the waveforms easily. And what is the difference between the carotid and internal jugular vein? Here it is more of phasic, two-phasing wave you are seeing. They are they are compressible, they are varying with the respirations, and with abdominal jugular reflex, they shows increasing the column height. So again, this repetition of same. So I want say that it is non-palpable, and it is easily reducible. Now, how to examine that we had discussed. You have to put a vertical scale between the two horizontal scale, and you have to measure the height, and you have to add the 5 centimeter, because the mid RA is 5 centimeter below the sternal angle. So you have to add 5 centimeter, and normal JVP should be, if it is less than 4 centimeter, meaning if you add 5, it should be less than 9. And if you convert into the water, it is 1.3 centimeter of water is equal to 1 millimeter of mercury. Now, first we have to see whether the pressures are raised or not. So you are measuring the column, you have to see whether you are dealing with the raised pressure. So anything above 9 centimeter with adding 5, or only 4 centimeter without adding 5 centimeter, it is raised JVP. And which are the, and you have to see whether it is non-pulsatile or pulsatile. If it is non-pulsatile with the engorged vein and raised JVP, it usually having a SVC obstruction. And what are the pulsatile but raised JVP causes? The cardiac causes are right-sided failure, any conditions with a severe PH, constrictive pericarditis and all. Okay. So, the elevated JVP, the cardiac causes are, we are dealing with the low RV compliance, or inflow is incompetence, or a circulatory overload in the form of any fluid overload state, and others are like SVC obstructions or COPD. And this is again, if the JVP, you can't elicit it, is pulsations are sometimes goes beyond the earlobe and the whole veins are engorged, then you have to raise the hand. And when you have to see the angle between your sternal angle and what angle the veins are collapsing. If it is less than 4 centimeter, that means it is a normal RA pressure. If it is more, then you are dealing with a increased RA pressure. Now coming to the waveform, there are 2 positive waves and 2 descents. The visible waves are A and V, and descents are X and Y. So we will discuss each of them, but again I would say the timing is very important. With carotid, if it is precedes the carotid, it is A wave, and it is after the carotid, it is V wave, or you can coincides with the heart sounds also. Now what is A wave? It is the first positive deflection, and it indicates the effective RA contractions, and usually it is dominant wave compared to V wave, but it usually precedes the upstroke of the carotid, but it follows the P wave. And the X descent is, it is a systolic through the C wave. So it is a fall in RA pressures during the early systole. So the RA is getting pulled, the tricuspid valve is pulled off, and that's why there is descent is visible. And the C wave is, again, it is interruptions of that downward pull by the positive reflection, because there is upward bulging of the closed tricuspid valve, and that during the isovolumic contractions phase. The V wave is the end of systole and the early diastole. There is another one positive deflections, and it usually roughly synchronous with the carotid. And X descent. What is X descent? It is again a form of atrial relaxations during the atrial diastole. And the Y descent is all passive filling. The tricuspid valve is open up, and the whole passive filling of the right atrium to right ventricle is, so RA is emptying, and that give rise to a Y descent, rapid Y descent. H wave, you can remember, but it is a wave for the slow motions, and it has been described in 1907, but it has no much clinical benefit. So, as a clinician, we have to see, first of all, what are the outward waves and what are the inward waves, and in the position of the patients, the leg raising, if it's not visible, you can put gentle compressions on the abdomen, that we will discuss. Or a patient is hypovolumic, make him euvolumic, and then assess the wave. The difference between the A and V wave, as I say, one is active contracting phase and another is passive, and one is preceding the S wave, another is after, and usually it is A wave is taller compared to V wave. So A wave is usually normal wave, it is a prominent wave. So what are now abnormalities? The prominent A wave is seen here, the atria is contracting against the resistance. So that will give rise to a giant A wave. So in any RV inflow obstructions or any pulmonary outflow obstructions, PH or PH situations or RV cardiomyopathy, you get a A wave giant. And if the asynchronous contractions in a closed tricuspid valve, that give rise to a cannon A wave. And cannon A wave, it could be a regular or it could be a irregular. Depends on. So JVP not only helping us into the diagnosis of the volume status, but also diagnosing certain arrhythmias also. And in exam, if candidate has been given a case of mitral stenosis and he has been asked to demonstrate the JVP, and if patient is in atrial fibrillation and he said A wave is present, then he has a return ticket. It is a, because A wave can't be possible, atria is fibrillating, there is no atrial kick, so A wave is absent in atrial fibrillation. Prominent V wave, usually they merge with the C wave, and most common CV complex prominent pulsatile wave are in a patient with tricuspid regurgitations. It could be either organic or functional, whatever. The prominent V wave, again I said, severe TR, MR or any volume overload state. Now absent X descent, it is again, as I said, okay, there is a CV complex, so X descent will be absent in a patient with a tricuspid regurgitations. Now the patients with slow, I would like to focus on the slow Y descent. The Y RA is emptying, but the RV filling is impaired, and it usually gradual in a patient with tricuspid stenosis, pericardial. So TS patient always make an attempt to see multivalvular case. You are hearing the murmur of this thing. The patient is in congested state. Always make an attempt to see observe the JVP, whether you are dealing with the slow Y descent or rapid. And rapid Y descent, again severe TR in a constrictive pericarditis or severe heart failure. And lastly, the word about the hepatojugular wave reflux. Here you have, again it has been said, patient should be, if your JVP is not visible, make the patient relax, abdomen should not be tight, and your periumbilical area, you have to apply a gentle pressures of 10 seconds, and you have to see the durations, the rise of the venous column. If it is more than 5 centimeter, then it is, if it is persistent or it is a sudden fall, then if it is more than 15 second, 25 second persistent, then it is abnormal. So I'll just say, so here why this happens, if RV, incipient RV compliance or RV failure, RV is not able to accept the extra load on it, so that give rise to a increased jugular venous pressures, and it will take some time to fall it. So this is how I would say, these are kind of 4 response you will get in a hepatojugular reflux. One is a flat, that is a negative. Second thing is sudden rise and the fall, but the positive would be it sustained more than 4 centimeter rise, and it sustained for more than 25 seconds. Now the respirations. Normally, because of the during inspiration, the JVP falls, but in Cushman signs during inspirations, Cushman signs happens in a constrictive pericarditis where RV can't accommodate more blood, and that time during inspirations it increases. And this is how you should differentiate cardiac tamponade versus constrictive pericarditis. You can see in cardiac tamponade, what are the triad of cardiac tamponade? The muffled heart sound, hypotension, and the raised JVP. And raised JVP, here the X descent is prominent, but the Y descent will be slow. Whereas in CP, it is a W pattern, the X and Y descent, but rapid Y descent, and they are more prominent. Okay, so constrictive pericarditis that we have discussed. So double descent, always think the wide, focus on the wide descent, if it is slow or rapid, and then you can diagnose. And in exam you have been asked to draw a JVP. So always, whenever you are reading, just make an attempt to understand and draw it in your way. Because these are the common etiology and you should know the waveforms, and always make an attempt to draw ECG below. Because examiner should know which part of systole and diastole you are drawing each waves. And this is a classical of TR, the CV complex being prominent, and depends on the severity, it happens. Now, what about the congenital heart disease? Because that is also part of your syllabus, and where you have to see the integrity of IAS and IVS. If septum is largely defect, then JVP is normal, because both ventricular pressures are isolated, so there won't be a transmission of any wave. But if septum is intact in a patient with severe PS, there will be a reflection of large giant A wave on the JVP. The pulmonary hypertension, again, it will be a reflections of a wave, CV complex and all. In a patient with ASD, again, normally, normal isolated garden variety ASD without pH, A and V are equal, but severe pH, all the findings of raised JVP and the CV complex and all. But JVP in VSD and PDA, it is difficult to diagnose because it doesn't carry much information. Sometimes they said, as JVP has a connections with pulmonary capillary wedge pressures, can it reflect the left ventricular state? It may reflect in a patient's, it should not be taken as a direct marker, but yes, in indirect marker, it can reflect in a patients with HepPEF and all. That we had discussed. Abstinence anomaly, I think it is the same of a prominent A wave, that Himalayan P wave you can get on the ECG at that as a direct relations, indirect relations with the prognosis of the patients, and how much the atrialized RA is. Now the cyanosis with the prominent A wave, that is a very important slide, because that the cyanotic heart disease, you should know this. So if septum, again I would say, that indicates the septum is intact. So you are dealing with either ASD with severe PS situations or Eisenmenger PDA where the JVP can be raised, but not in Eisenmenger VSD. VSD, large defect, the pressure equalize. So VSD, usually the JVP is normal, but ASD and PDA Eisenmenger, you may get a pH finding on the JVP. I will not go into that detail. And cyanosis with the elevated JVP, yes, in a patients with increased pulmonary blood flow, parallel circulations like a TGA, tricuspid atresia, or PPH with RV failure, you may get a RESA or adult tetralogy fellow. All of you should know our Indian author who had contributed good work on the adult tetralogy of fellow, and their article you should read. And the second thing is JVP with the cyanosis with the normal JVP. That is, usually silent heart is usually a tetralogy of fellow or a pulmonary AV fistula. Now, I want one of you to answer this. रिव्यू हो रहा है सर? He will make his effort. I had played, taken sir JVP, so they can, what we spoke, they can identify and understand. That I want to check. Okay, any questions about the JVP? It is difficult, but if you practice and it takes less than a minute to examine the JVP. So make an effort, at least in your day-to-day practice, to see the neck veins and correlate with your findings. Okay. Otherwise we can, I will, if it is run, I will have a clip in between, photo.
I think students should feel free to express your doubts on JVP. Many of you would have doubts. I don't. I agree. If all of you say you're thorough. Madam is very passionate. She collected a lot of information. Feel free to discuss. No examiner to fail or point. Yeah, please ask. Yeah, go ahead. Give a mic to them.
Hello, excuse me, ma'am. Ma'am, what is the difference between giant A wave and Canon wave?
Yeah. Giant, yeah. Canon A wave and giant A wave means in giant A wave it is because of the pathologic first of all difference, but the Canon A wave is a flicker movement. Giant A, and it has more descent, and it, because here the atria, there is a desynchrony between the atria and ventricle, and it can be regular or irregular, whereas giant wave is always being a regular. Okay, that clipping I had kept, but it is difficult to show to you. Yeah.
You'll sense it will work.
The Canon airways usually you see in a patient who's got a complete heart block. I think that's what she meant, that there will be dysynchrony. So a patient who got a complete heart block, because the ventricles are beating at their own way, the atrial contraction occurs many times at the closed AV valve, and therefore there is a giant A wave. So that's what it looks like, a Canon A wave. That's what it looks like.
Actually, Canon wave and giant A wave should be separated. A wave is a pre-systolic event. Canon waves are systolic events. So that is one of the major differences. And mechanism Dr. Hetan already told. So that is what is usually expected in the exam. A wave, pre-systolic. Now how easy it is to make out is a different thing. But on the recordings, that is what you will get.
Unfortunately, what happens nowadays when you see a patient on the bedside, nobody even unties the top button of the patient's shirt or the hospital gown to look at the neck. And the first thing that patient looks at nowadays is at the radial artery or the femoral artery pulse, whether that is available for doing a coronary angiography or not. I have seen this. And so I think the whole idea of examining a patient has changed. But I think before we do all that, we must know the basic examination, the body of the patient, the symptoms of the patient. Whatever artificial intelligence, of course, it will come. There will always be a kind of a interaction, has to be an interaction between the patient and the doctor. Until unless the patient knows that you are a doctor who is going to treat you or treat him, he will never gain a confidence. He's not going to get a confidence in the machine. He's going to get a confidence in the human. So eye-to-eye contact is the most important thing. So I don't think even artificial intelligence comes, Shiv. The human contact is, and eye-to-eye contact is not going to change. So rest assured all physicians that we are going to have our own bread and butter, is not going to go in the hands of the computer scientists.
Madam, one more thing, many students we keep asking me doubt is, this business of lying flat and 45 degrees and making them sit. To make them understand, it's only the method to make the upper level prominent. You can Just highlight those points regarding the position to see the JVP and how does it help.
Yeah. As we had discussed, 45 degree is always a better thing, but if patient is hypovolumic, and then make it slightly supine to elicit the JVP. And patient is having a CCF and all, so you have to make it big. It can't be lie down or even in recline. So that time you have to change the angle. So depends on the volume status, you have to change the angle. Okay.
But I want more questions, because what is happening is the examiners are getting so excited and they're all telling their own experience. I would like that, only one question has come. Please ask more questions about it if you have anything. Everybody is clear about JVP? Oh, go ahead. Yeah, somebody is raising the hand. Go ahead. Then we'll take an exam now.
Most of the time, when we examine JVP, A waves, they tell it is lower position, it is a flicker of contraction, and A waves are higher up in the neck, like a most visible thing. Is it okay? Whatever understanding we got.
What was your question?
The A wave, normally they see that it is a flicker of contraction in the lower part of the neck. And if you want to comment on V wave, then it is higher up and it is the most visible thing, not like a flicker.
No, usually A wave is more prominent than the V. Unless the patient is having a tricuspid regurgitations or anything, that time V will take over. But usually CV complex is more prominent and AFib, you can see that. So always correlate with the better timing with your carotid. And then you can take a judgment whether it is, because normally the A wave contour is bigger than the V wave.
We want to see the V wave.
Huh.
Better to see the upper part of it or anywhere.
No, it is two positive waves are the, so one is before and one is outer. And these are our outward pulsations. And the descents are inward pulsations. And you have to correlate with the carotid, that's all.
Hello. Ma'am, hello. Excuse me, ma'am.
Yeah.
Hello. Do the GVP changes with the change in angle, ma'am?
1 second, let's watch the video.
Hello.
Then after that we'll- So I think there is some transmission problem. It is as you said rightly, that it is as difficult as JVP. Okay, so it's.
I want one volunteer, identify the first one and second one, what is what? Can you see in the first lady, whatever the patient, the pulsations are more of a lateral and they are a large CV complex of a severe TI, whereas they are a GVP pulsations. Whereas here you can see the pulsations are it is a throbbing pulsations at the middle end of the base of the neck, and they are because of the carotid aneurysm or it is a carotid pulsation. So you should able to differentiate whether you are dealing with the JVP or a carotid pulsations. Next. Yeah. This is very easy. Identify. Okay, I'm giving you the hint. The graph. Yeah. Can you? One person, please. Yeah. Pardon? Mike.
AF there.
AFib.
Yes, good. And with a prominent CV complex. Yeah. Yeah. This is
TS.
what is the diagnosis?
TS. Yeah. Prominent A wave. TS.
Prominent A wave, and the Y descent is
Absolutely.
slow.
Tricuspid stenosis, ma'am.
Yeah, but you can see the prominent X descent also. So it could be because of cardiac tamponade. Okay, next. Okay. Can you see one flicker wave? And there is a very, all of you can just see on the Google, very good video recording by Dr. Paul himself for all the GVP pulses. I have taken a few clips from that. Second, see. They both are the similar. What is the diagnosis? Can you see just the flickering wave? One is regular, another is irregular. It's a Canon A wave. Next. Next. Yeah. Last. I agree. Here the not that much, but here the descents are more prominent than that. It's a case of CP. Next. Next. Yeah. Okay. Thank you. So always see the outward movement, inward movement, and the relations with the carotid, and make examinations, any examinations in a segmental approach. First, see the level, make the patients in a proper positions, and check the pressures and then the waveform. Thank you.
Okay, with this, we'll take a break for 15 minutes.
I have a question.
Who's this?
Since this A wave will precede carotid and V wave will succeed carotid, since we are seeing in continuum, we cannot differentiate between any points. But we are seeing in continuum, we are not palpating and we are seeing the carotid. One wave is preceding the carotid and one wave is succeeding the carotid. We don't know which is which. Differentiate A wave or V wave. Ma'am, can you demonstrate on
He's asking without palpation how will you
Heart
know?
and the murmur. You have to at least auscultate for 2 to 3 cycles. Then you can diagnose whether it is systolic event, diastolic event, and you can time the murmur. Okay?
Ma'am, can you please demonstrate on how the Gardner method is performed?
Who is there?
I don't know.
What was the question?
Repeat your question.
Demonstrate on how the Gardner method is performed, how the measurements are done, which waveform is visualized.
analyzed and how the hand is placed on this sternum?
I can't get. So what was the question? Gartner method that you have to just raise the hand and you have to see what angle the veins are collapsing compared with the sternal angle, and that height you have to measure. If it is less than 3 centimeter, that means it's a normal.
Are we supposed to look at the veins in the arm, forearm or the hand?
Wherever the veins are prominent. Okay. Yeah.